go back to the previous lecture and start talking about some of the most practical issues that we have. So in a short, our mission is to replace the islets or the beta cells, as you can see here, because they have two important functions that we need to replace. One is the insulin synthesis capability, and the other one is the sensing capability. Our wish to solve both the insulin issue and the glucose sensing issue has developed between the different years until recently there was this brainy guy who was able to put these two together and have a glucose level defined insulin secretion. So the coupling of monitoring of glucose to insulin secretion is our holy grail where we want our patients to be. But before we go to this solution of combining these two, we need to know that this is based on all the cumulative knowledge that we had with insulin secretion or insulin injections and glucose monitoring. So now we're going to discuss this step, the step before the artificial pancreas, and that is the pump. And we need, in order to know how to work best with the artificial pancreas, we really need to know and understand how to work and get the maximum out of the insulin pump. So we heard about the different components. I'll jump straight to the fact that to know and get maximum out of pump therapy, you need to be familiar with pump therapy. You have to be comfortable with pump therapy. And the best is, now that we have media, is go to media that is respectable and gives you reliable data. And I'm happy just to show this. This has nothing to do with a company or a commercial. This is the ESD site that has just put in very nice e-learnings on technology. And I urge all of you who wants to get more familiar, it's not that difficult, but get sources that can teach us how to use pump therapy. So what is the major advantage of pump therapy? Believe it or not, what is more advantageous in pump therapy versus a long-acting insulin is one fact, that we can stop it. The fact that when you inject insulin that works for 96 hours, we cannot say, okay, this is too much, come back. Pump therapy, the number one advantage that I see as a long-term user is the fact that you can stop insulin. So that is why you heard before that you can actually mimic is mimicking by the fact that you can decrease insulin at specific times as you wish, either by programming the pump, and let's go just first here. You have seen this before. You can program the pump to go lower at midnight or the early hours of the day or during the afternoon when the people with diabetes actually are exercising. But most of all, you can teach the patient to use temporary basal rates when he's going low, when he's exercising, or when something is wrong. This is the main advantage that you don't have with long-acting insulin. So use it wisely. So I would say my first tip is program basal rates to prevent hypoglycemia and educate the user to suspend or use temporary basal when needed. This is something you cannot get from MDI. Number two, the bolus wizard. You heard the advantage of the bolus wizard. It's not a theoretical advantage. The bolus wizard is the tool for you, for the patient, to follow your orders or your recommendations, because by using the bolus wizard, he gets consistent and more accurate boluses each time he boluses. He doesn't need to reinvent the wheel every time he uses a bolus. And this is important not only from a ease of use for the patient. He doesn't need to calculate all the time. It does by the calculator on the insulin pump. But it is also a part of getting the therapy persistent, consistent, and later on we'll show you that the other advantage in giving back the data coming from using the wizard calculator. It takes into account a very important part of therapy that patients cannot know when they use MDI, is the memory. They cannot remember every day when did they do the last bolus, and what is the effect of the previous bolus on the current bolus. Again, the fact that it's done by a computer in not a very sophisticated way, it's enough for him to prevent him from over-bolusing, overcorrection. So the use of the wizard is not just a nice to have. It's an essential part of using insulin pumps in order to get to the outcomes we want. So tip number 2, utilize the bolus wizard with every bolus. And what I do with my patients, the first thing I look at the downloads, and I'll talk this in a minute, is to see if he's persistent in using the bolus wizard. We already have papers. The more you use the bolus wizard, the better the outcome. So it's part of the teaching of using pump therapy is using these calculators on a daily basis. The third issue, what's different between MDI and pumps is that that pump therapy can again remember all the boluses, all the, I would say, the patient's activity of the day, how much he ate, if he did exercise, and this is done automatically. You don't ask the patient to engage with another application. The day-to-day use of the pump therapy by itself gathers a lot of information that can then be downloaded into data management systems. So another strong point of the pump use is using data and treating patients based on data, not on diaries that we know are very unreliable, but using data coming from objectively collected from the bolus wizard can give you a picture, an accurate picture of the patient's behavior and the patient's treatment in order for you to then improve his outcomes. If you're not sure what he would have done in the past, how can you give him new suggestions for the future? So the next tip will be, and this is when we have time, we can discuss this later. So the third tip is use data. Use data to treat your patients. The third thing is, what's important for the patient is not the box, not the pump itself. What he feels closest to him is the infusion sets. And we tend to forget about this. We think it's trivial. It's not trivial to the patients. He needs to know as much as he needs in the simple way of how to put the cannula in. How far should he use it? Unlike the insulin injections that you want it to be the shortest, the shortest needle, probably for pump therapy we wanted longer needles because we want it to be more stable under the skin. So maybe you'll use 5, your pediatrics, I'm an adult endocrinologist, so in peds you use 5 millimeters, you use slanted infusion sets. And the point is, for a pump therapy, it's better to have longer than shorter, unlike the needles that you use for injection. This is a major, I would say, underreported issue is the skin reactions that really bothers the patient but does not change A1C. But we need to take into this account. So we really need to understand insulin infusion and make sure that we train our patients and also our staff how to decrease skin irritation and get the best outcome for our patients. So the tip number 4, educate the user and the staff on the proper use of the infusion sets and skin care, and instruct the user to change the sets regularly every 3 days, unless in the future, and I'm telling you a secret, not long into the future, we're going to have sets that can survive more than 3 days. And the last but not least, I got 4 more minutes to go to a very important issue that Dr. Kulkarni just discussed in our previous lecture. When you look at meta-analysis that compare MDI to pump therapy, you see a difference of 0.2, 0.3, maybe no difference at all in A1C, and you say, why? Why is it worth a 0.2% difference in A1C? So first of all, 0.2 difference in A1C is important to be lower than higher. But the other thing is that those are meta-analysis of different studies, and if you see the heterogeneity of these meta-analyses, it's like comparing apples to oranges. So what did our good friend Professor John Pickup had actually looked at all the meta-analysis and looked at individual data, not just looking at data from the studies themselves, but the individuals who actually were in the studies. He found a very interesting finding, that the higher the A1C is when treated by MDI, when switching to pump therapy, you get higher advantages in A1C reduction. He even came up with this kind of calculations. Show me your A1C on pump therapy, I will show you how much you're going to get lower A1C with pump therapy. So if you take meta-analysis of all the studies in which the A1C when you started pump therapy was about 7%, you will get hardly this 0.2, 0.3 reduction. But if you take studies when the A1C at baseline was higher, you're going to get up to 1% reduction in A1C. So this is the way to look at the meta-analysis or the different studies. And the same is for hypoglycemia. If you take patients with very low rates of hypoglycemia, you will not get lower than 0 when you change to pump therapy. But if you take patients, as has been mentioned before, that have many episodes of hypoglycemia. Remember the DCCT, it was 60 episodes per 100 patient years for those who were treated more intensively. If you take these patients and you put them on pump therapy, you get a reduction of 80% of hypoglycemia. So you have to not to look at meta-analysis when you treat your patients, but look at your patient's criteria in order to get the expectations met. And I think here's the tip number 5. Proper patient selection and setting user expectations. So if you have a high A1C, you can promise decrease in A1C. If you have high rates of hypoglycemia, you're going to have a reduction of the hypoglycemia, but not the other way around. And the second thing is, and I just pushed it in because I didn't know where to put it in, a very important tip to get success of using pump therapy is make sure that the patients are measuring the blood glucose in a regular fashion between 2 to 4 times a day with SMBG, and depends on the ability and the reimbursement, or CGM. Because if you do not use SMBG, you might go into the trouble of DKA. So why do you have some studies that show an increase of DKA with pump therapy while other studies show the opposite? It's all a matter of the SMBG measurements per day. If you measure 4 times, that means every 6 hours you have a measurement, you will not go to DKA. You'll have less DKA using pump therapy than using MDI. And with this, I think I can summarize those important tips, how to take the theory and get success in your daily practice with patients on pump therapy. And thank you so much.